Hi everyone, my name is Mario Espino. I'm the chairman and founder for Complete Care Management Services, otherwise known as CCMS. It's not a play on words. We actually mean the name of the company. It actually has a meaning for it. It's Complete Care Management Services. So complete care management today is something that you find in CMS. It's clearly defined what its intentions are. They continue to add more things. In 2025, they're adding more things. I know I don't want to get too carried away. I want to tell you that I'm very happy that you're here with us. The intent of this podcast is to bring out and tell you about things that can help manage those chronic diseases and help those patients stay at home that otherwise would be not stable at home. So, and a lot of it's going to be based around issues in their home, whether it be social or psychosocial. So a lot of great things you're going to hear about here. Things that you can use for yourself, things that you can use for a family member, whether it be your mother, your father, your sister, your brother, a friend. There's always people that are in need of these specialized services that we offer. We're definitely, the nuance in the healthcare field. Nobody else is doing what we're doing. I come from a long background, just to give you a little background on me and how I got here and why I think that, God's given me the opportunity to be able to do what I'm doing today and be successful at it. It's because that my knowledge in the 44 years that I have in the industry have been, not in one specific area. It's been in the hospital, it's been in the nursing home a little bit, and it's been in acute care, other acute care settings, and it's been in the home. And then not only in the home, but DME, home health, hospice, the services of primary care of a primary care doctor, the importance of preventive medicine. All of these things are key factors in being able to have a successful, quality of life for those people that have chronic diseases. So we'll get started. The success around a company has been built around, the nuances in the healthcare or organizations out there, mostly the government, that they wanted to and try to understand how is it that they can better manage these chronic diseases. They know very well that the more touch points you have with the patient, the more opportunity you have to see them in their environment, the better you're going to be able to determine whether or not they can manage their disease. So, I want to focus a little bit and, try to get this particular first podcast right in that space, So our success is that we do everything at home. Our success is that we line up other services and stack them one on top of the other so that we can provide the best care at home. The other side of the services are on the psychosocial side, social determinants, whether it be food or food and nutrition, transportation, money. There's a litany of things that happen in the home that can hinder the ability for that particular person to take care of themselves. And it's crazy, but hey, what about a 93-year-old taking care of a 95-year-old, and that's the couple that lives at home, and they want to live at home. They want to live the rest of their life at home. They want to have a quality life at home. That's all available to them. The problem is that there's no one that spends a lot of time to be able to determine and see what are those obstacles that are happening in the home. So the home is where it's at. And we definitely are the leaders of care at home. You're probably wondering why we started this business. I got to take you back a while, back to, the early 1990s when ICD-10 came about and meaningful use came about, and, me staying in a space that's called Center for Medicare and Medicaid Innovations, which is the futuristic space of where the government tries out new programs. It's called CMMI, Centers for Medicare and Medicaid Innovations. There's a Centers for Medicare and Medicaid, which is where the generic everybody lands in, and then there's a CMS for Indians as well. Those are the three CMSs that exist. But CMMI particularly is one that I've spent a lot of time in that space, and particularly in the accountable care space, where you're burning a candle at both ends, so you want to create best practices, and best practices is actually something. It is a word. If you look it up, it means how can you provide the best that you can for those patients. That's what you call best practices. So it encumbers a lot of other things, but best practices is an actual word. So my job was, how do you get best practices and actually reduce the cost of providing the care? So you're at both ends here. Very hard to do if you don't know the space. But I was very fortunate to understand the space and be able to collaborate a lot with CMMI and other organizations, and led the way, sort of paved the way on these moonshots that exist out there that were ideas that were founded in good theory, but nobody actually had done them. And we're doing that today. Let me go back a little bit and tell you a little bit about how it is and why we started this business. I was working with a next generation ACO. Some of you will look it up and some of you won't. I suggested it wouldn't be a bad idea just for you to understand. There are accountable care organizations that are in the general pool, and then there's accountable care organizations that work with CMMI as a regulatory body, not with the Centers for Medicare and Medicaid. Typically, they get to do more things that are innovative, more things that are not able, the other ACOs are not able to do. But you got to be very good at what you do in order to be able to be successful there. The government knows that in managing, and obviously care management, and there's other words that the government is using now that are management related. The government understands that the better you manage the patient, the more control you're going to have over the outcome of that patient's quality of life, and ultimately affect the money. I've been one that has been always looking at how is it that I can look at the cost and make sure that we're getting quality services at low cost. Because you can get high quality and high cost. Those are not the ones that you want. You want the high quality with the low cost. And what are those people doing that is different? And sometimes you find out and sometimes you don't, but you keep on looking for what are the keys. And what I can tell you today is, and it's part of our tagline, Leaders of Care at Home, and we are definitely the leaders of care at home because this is not a moonshot. We've actually paved the road for many others to come along, and we're automating our systems today to be able to farm this out and get it out to more and more people, because the people that we have on our service today are extremely happy that they have this service. The alternative is for them to end up in some other organization or another service where the people that are there are typically end of life. Maybe hospice. I know that the hospice community is not going to be happy that I'm saying this, and there's a beautiful space for hospice and there's a beautiful space for us. And we have not been part of the conversation in the past. So hospice has been getting a lot of patients, some of them that don't qualify. Some of them just because the families need round-the-clock care, they put them there. Some of the patients that get into hospice are because in an adult living facility, they can't have someone that's bedridden unless they're on hospice. They want to keep the patient, so they put them on hospice. Is that the right ideology for them at that point in time? Some of these patients that are bedridden are going to live for years and years and years. They don't have any other than some type of something that happened to them that limits their ability to move. But their minds are good, their organs are good. But the piece with hospice is something, again, it's great. I have family members that have been placed on that. I agree at sometimes and disagree at times with the service and how it's done, but there's an alternative to it, and it's CCMS, Complete Care Management Services. We can help you stay at home and lead a successful, quality life at home, and that's what you want. You want to stay there. Most of our patients tell us that thank you for being able to provide these services that otherwise, if we didn't have them, we wouldn't be able to stay at home. So it's an incredible opportunity that we've been given. Coming out of that CMMI program, we saw that there was an opportunity under two different programs called Direct Contracting Entity, which was part of one part of the program. The other part was called Primary Care First. So one was 5,000 patients and under, and the other one was for 5,000 patients and above. The Direct Contracting Entity piece was for that. And then the Primary Care First was single primary care doctors that could either get involved with the program or not. And the idea was that the government was going to auto-assign patients to the program, whether it be on the DCE side through some primary care doctors that were associated with a larger group, and that larger group was managing those primary care doctors, or it was a solo doctor that had 200, 300, 400, 1,000, or 1,500 patients, and they were entering the program individually. And once they entered the program individually, whether it be through the DCE or the DCE manifold, or through the primary care first piece, where they were individually involved in the program, they had an opportunity to become seriously ill population providers and primary care providers under the program, or they could just be primary care or seriously ill. We decided to be seriously ill. Obviously, we got approved in 2019 for all the counties in the state of Florida, with the exception of 2 zip codes, which is an incredible accomplishment, for an organization like us. We've always been, and I've always been surrounded with technology. We brought in heavy technology in here, and we use and we leverage it. Today, we're, actually looking at artificial intelligence, not futuristic, but real time, things that can happen that can really mean, but that are founded on simple logic. So if you use AI and you base it on simple logic, things that are based on how we can manage those patients, it'll help us in the long run. So great things. Just to finish the idea where how we started. We started in that program, which was primary care first and direct contracting entities. Again, this is a CMMI program, so Centers for Medicare and Medicaid Innovations program. And one of the key factors was deciding on SIP or not, SIP, so the acronym is S for Sam, I for India, P for Peter. So seriously ill population, not a really tough acronym to abide by, but we decided that we were just going to do the SIP piece. Obviously, 2020 comes around, we get into COVID. COVID sort of mandates everything. People work out of their home, including the staff for CMMI. We don't get to be onboarded. But the most incredible thing is that we continue to work like if we're going to be onboarded, because we are told by CMMI that we will be onboarded in Q1, Q2 of 2021. Well, obviously Q1 and Q2 of 2021 come around and we don't get onboarded. So we're in a fee-for-service world. The fee-for-service world doesn't know about this program, doesn't know that you can have very sick patients and report positive things. The fee-for-service world is interested in knowing, hey, the patient was sick. The government is interested in knowing the patient was sick. You're billing me for something that you did to resolve an acute issue or a serious issue with the patient. Here we come along and say, hey, listen, we're going to start documenting and managing these patients that don't currently have at the moment an acuity. I think it's also important that we talk about our relationship with some of the tertiary hospitals down here in Dade and Broward County, and what we've been able to do with them, and as far as reducing the number of patients that come back into the hospital. The standard for Medicare today, and it's well documented with multiple studies, is between 17 and 20%. That means that out of every 100 patients that leave the hospital, 20 of them return, within a 30-day period. Our numbers, just to sort of be quick and tell you that there's a future in another podcast where we'll talk in detail about that transitional care and that program, where we're actually a readmission reduction program that reviews the admissions that come in 30 days again and over again, just to become better and better at determining what other things could have been done that could have reduced that or mitigated that hospitalization. But our numbers today are somewhere around 3%. That means that you do the math, we're looking at a 500% reduction in the 500 to 600% reduction in the hospitalization, readmission rate for hospitals, which is a win for the patient. They don't get in there again, to resolve something that could have been resolved with a better management of that transition between the acute care facility and the home. But everybody wins there. The patient wins, the hospital wins because they don't get deducted, a penalty, and the payers win because they don't have another patient in the hospital that may get something else that may come in, in a future admission because of something they received from the hospital. So, and we'll, in other podcasts, we'll talk about the studies. We'll have one podcast on a study that we did around the hospital discharges and what happened, with a population that's supposed to be 8 to 12% admitted into the hospital. We did this study with 5,000 patients, 500. Out of the 500, we picked 50 that had multiple chronic conditions, and we measured, when they started with us and when they went back into the hospital. Some incredible stuff. I'll leave that out. I'll tell you about it the next time. So, so you listen in to our next podcast. But we started there, we started with the government program supposedly auto-identifying vis-a-vis some algorithms they were writing, the number of hospitalizations, the number of medications, the number of chronic problems that they had, and they put that into an algorithm, and they were going to scrutinize all those patients that met, and then they were going to reassign them to team members that were approved for the primary care first SIP piece or the DCE SIP piece. And we never were on board because of the COVID thing. So some challenges along the way, many times, many people said, hey, stop, you're putting all your money into this, it's never going to work, because it's obviously a very hard thing to do when you're in the patient's home, and to drive your personnel and doctors to be in the patient's home. The doctors and the allied professionals rather get them in their office, so they don't have to drive around places. So it's special people that we need to employ to be able to do this thing from the doctors down. I applaud all of our people, and we're blessed to have the significant number of well-educated, most of them, a lot of them being foreign graduate, doctors, that help us, because that information, they have it with them, whether they're a certified medical assistant or a nurse or an RN. You know what you know. Then when they walk into a patient's home, they're going to be able to see if there's some problems going on. So we're very excited about the future of complete care management, CCMS. There's a win-win-win here with CCMS, and it's true. It's true because the patient wins, the doctor wins, and the payer wins. And it's the patient, the payer, hospital, physician. Those are the triple P's and the triple wins. The payer, physician, and more importantly, the patient wins. Very excited to have these podcasts and talk to you and open your eyes about, hey, keeping mom, dad, your brother, your sister, an aunt, a relative, a friend at home with CCMS. We are and can be the solution for them having a quality life at home.